Hello everyone, welcome back to my channel. In this video series of type 5, I just want to show you 5 most important diagnoses that everyone should know for neuroradiology specialty when you're working through the ER or evening night call. So these are the most common indications and every junior resident need to know. So specifically, I just wanted to show the basic concepts that is going to be a little bit like intimidating for more junior residents when they start call like nearly in July. So there are a few months left, so you guys need to be ready. So let's give you some tips on how to help you to survive your night call. So the first indication, the first most important thing that we need to know is intracranial hemorrhages, which is very important. We shouldn't miss this diagnosis. Patient come to the ER with trauma, fall, different type of a story, and we need to look for hemorrhage. Okay, on previous videos, if you guys didn't watch my previous video on head CT, I talked through the basic head CT interpretation, how we look for hemorrhage, fracture, or other important stuff on head CT. So make sure you watch that one before looking at this video. Okay. So this is a patient coming like through ER with fall, and then we have different sequences. We have the axial, we have the coronal, we have sagittal, and this is a bone window. So first, I would like to show you guys the axial sequence, and we are looking the search pattern that I told you before. I just walk you through the findings. So first of all, when I look at this very quickly, so I see there's a lot of areas of hyperdensity in the brain parenchyma in different areas. So basically, hemorrhage is going to show up as hyperdensity on CT. So it's going to be similar with other part of the body. Hemorrhage usually is going to be hyperdense. And when you put like your Houseman unit, it's going to be about 40. So that's how you know this is hyperdense compared to the normal brain parenchyma. Okay, so now we need to know it's not just enough to say there's hemorrhage. We have to, these hemorrhages, we have to characterize them, and it's important to know what type of hemorrhage we have because they have different type of prognosis for neurosurgery, and we have to measure the hemorrhages. Some of them I will tell you which one you need to measure because also they are important. They can grow fast, and they need to follow this up like in a specific time window in order to make sure the patient is stable or is just getting worse. So we have to just make sure to put detailed report for our providers. So first of all, so we see all these areas that they are hyperdense. They look like in the parenchyma. They are mainly in the bilateral frontal lobes, specifically inferior frontal lobes, and then anterior temporal lobes. So the areas of hemorrhagic contusion is mainly in the anterior, inferior frontal lobes and anterior temporal lobes. This is the most common area that patient get contusive injury. It's important to just mention these are contusion, and the reason for that is these are not subarachnoid hemorrhage, these are contusive injury, and you see there are like edema around these hemorrhages. You see that these areas of like hypodensity around the hemorrhages. It's important to characterize them as contusive injury because they can get big very fast. So it's important when we just tell our providers that the patient has these contusions, they know that they have to just look this patient more closely, and they just need to get another follow-up in 6 hours to make sure this contusive injury is not getting bigger because these are notorious to get very big and then patient get herniated and all stuff. So we have different type of contusive injury. There is surrounding edema, and then if you guys look closely, you see that these areas of hyperdensity that they are linear, overlying bilateral convexities. These are subdural. So basically, this is the brain parenchyma, this is skull, and then these hyperdense linear areas are subdural hematomas. So if you look more close, you're going to see more subdural hematomas overlying the right temporal convexity as well. So this is the second type of hemorrhage that we have in this patient. We have to measure it. This is just not very big. It's small, but still we have to mention okay how much like we measure it, because if they are really big, they can cause herniation and they can get bigger fast. So make sure to measure like at least one of them to say okay what is the biggest size of these subdural hemorrhages. Then in this patient doesn't have epidural, but they might have epidural hemorrhage. Make sure that you just mention if you see something that is sometimes we cannot be very firm on subdural versus epidural, but if there are some classic findings for epidural, make sure to put that in the report. Then the other type of hemorrhage that we usually see in the setting of trauma is going to be subarachnoid hemorrhage. So if you look at your cisterns that you see, this is a supracellular cistern, and we see some areas of hyperdensity. These are subarachnoid hemorrhage about the supracellular cistern area, as you see, and this is the MCS cistern that we have subarachnoid hemorrhage in. And the other common areas, Sylvian fissure. This person doesn't have like Sylvian fissure hemorrhage. He has it like higher up here, but we don't have it like this lower bottom. So there are some areas of subarachnoid hemorrhage. As you see, these are all subarachnoid hemorrhage about the rectus gyri bilaterally. And so it's not unexpected. Patient has a like very severe traumatic injury, and we have like different types of parenchymal hemorrhages, subarachnoid hemorrhages. You see that the subarachnoid hemorrhage usually is along the sulci and cisterns. So these are the sulci. You see that these hyperdensity linear areas is in the sulci. So it's important, as I said, to say these are subarachnoid hemorrhage because these are not getting that bigger that much. So if the patient has just isolated subarachnoid hemorrhage, they can just wash the patient. It's not going to grow that much. So different areas of subarachnoid hemorrhage, we have parenchymal contusions, we have subdurals, as you see here, different areas of subdural. The other area that I would like you guys look at it very close for subdural is along the falx. So this patient had some areas of like minor hemorrhage around the right polypharynx area. If you look at the coronals, this is very important for every single head CT. Look at your tentorial on the coronal, and then you see that this patient has also some hemorrhage about the right tentorial leaflet. So when we look at all hemorrhages that we had, there is another compartment that we have to check for hemorrhage, which is interventricular hemorrhage. And when patient has subarachnoid hemorrhage, we know that that's the way that they are going to transfer into the ventricles. That's the way the CSF is just moving in the brain. So if we see that this patient also has some areas of interventricular hemorrhage, if I window it down, you'll see that there is dependent occipital horn hemorrhage in this patient, which is expected. When you have subarachnoid hemorrhage, you're going to have some, sometimes, not always, but it's expected to have some interventricular hemorrhage. So next thing we have to talk about is what all these hemorrhages do to this patient. So we need to talk about mass effect. We see all these areas of edema. We have some like effacement of these frontal horns. That's one thing we need to talk. Does patient has a midline sheath? Not really here. We don't have a midline sheath here. Do the patient has uncoherniation? I don't see any uncoherniation at this moment. It just looks like not that bad so far. And then we need to talk about hydrocephalus. Every time the patient has interventricular hemorrhage, we need to think about hydrocephalus. So at this point, it's not that bad. We see the ventricles are not that dilated, but we have to keep an eye on it. Specifically temporal horns, make sure they are not dilated. Early signs of hydrocephalus is very important to mention and give an alert to clinician about it. Okay. So when I'm done with this, I describe all my hemorrhages, I describe the mass effect, I describe the midline sheath herniation and hydrocephalus. Then I would like to go to the bone window and just check for any fracture. So as you see, this patient has a lot of fracture. These are displaced fracture of the bilateral parietal calvarium. You see that there is a diastasis along the sagittal suture. So a lot of badness happening here. So we see a lot of fracture. And the important thing about this fracture is when you have these fractures over here, so always when you want to look for fracture, any soft tissue swelling helps us to just find the fracture lines. As you see, there is a scap soft tissue swelling here, and then we see the diastasis of sagittal suture beneath that. So that's another thing that helps us to find the fractures. Make sure always look at all three coronal, sagittal, and axial. Also is helpful specifically for kids, infants. Look for the 3D imaging because it's difficult for us to differentiate the sutures or like basically accessory sutures in infants from fracture. It's important to just always make it 3D for yourself to look for those. Okay, so this is very obvious now. You see that all these displaced fracture. We need to tell the surgeon, okay, how much displacement they have. And that's why they had like these subdurals beneath these fracture lines. The other important thing that we have to mention as radiologists is you see that these fracture lines and this hemorrhage is just abutting the superior sagittal sinus. So the location of these fractures, because they are crossing the superior sagittal sinus, it might cause venous sinus thrombosis. So we need to tell them, okay, you guys need to do a CT venogram to look for possible superior sagittal sinus thrombosis. So this is another important thing that we need to mention in our report. And if any of these fracture lines, for instance, when you look your actual sequence, if any of these fracture lines goes into the important vascular structures, like if you have a scalpus fracture that goes to the carotid canal, then you have to, or even if go to the jugular bulb, specifically carotid canal is very important because we might have arterial injury. And then if it goes into the jugular bulb, then we need to basically recommend them to do a CTA or CTV based on the structure that is getting involved. So make sure to like put these all on your search pattern and make sure in every CT you look for all these, specifically in these severe traumas. Okay, so important things that we need to look in a trauma patient. As I said, we have to look for hemorrhages, but we have to describe what type of hemorrhage they are. Is it parenchymal contusion? Is it subarachnoid hemorrhage, epidural, or subdural hematoma? And do we have subarachnoid hemorrhage, interventricular hemorrhage? And then second step, what all these hemorrhages do? Do they have a mass effect? Do they have midline shift or herniation? They need to go to the OR immediately, or they can follow these patients up. And then we look for hydrocephalus. And at the end, we always need to look for fractures and what fractures do to the patient. And also we have all these soft tissue stuff we need to look for. That's another topic that we need to look at the orbit, look at the facial structures. But for now, I just wanted to focus on the brain parenchyma itself and bone window for fracture. So if you do your systematic approach, you're just gonna get through all these and you will be fine. So don't get panicked when you are sitting at an ER as a junior first or second year resident. Just try to be consistent for your search pattern and always look for structures and look for pathology that you just need to know and search for it. Specifically in neuroradiology, we need to search for pathology to find it. It's not coming out of us. Like, we need to specifically look for different type of pathology in the neuroradiology. Okay, so first diagnosis, intracranial hemorrhage. Now you know how to do it. So if you guys enjoyed this video, please don't forget to subscribe and follow me up for the next topic for the ER cases. That is going to be a stroke. And I know it's a very challenging topic for junior resident and junior trainees, how to look at perfusion, CT, and a stroke. So don't forget to watch that video when it comes up. So thank you for watching me.